So it has fallen me to introduce our speaker for today. Are you hearing me? I'm hearing yes, no.
Yeah.
Yes? Yes?
Yeah.
Okay, I can hear me now too. So Joanne Heller, the other Joanne, she and I have been nicknamed by Scott as the Joanne in stereo. She was going to introduce our speaker today, and she was a little nervous about it and working so hard on it, and she's totally under the weather this week, so it has fallen to me. But that gives me a good reason to put a commercial out there, which is the Wellness Committee. We didn't just invite Jim Pier to come and talk because he's smart and good and my son. We invited him because we were working on a series of presentations involving cognition. Because you maybe haven't heard this here, but every now and then somebody says, oh my God, I can't remember. So Jim became the centerpiece for our series. We will offer a presentation on resources available in the community for caregivers of people who have cognitive issues. And on November 18th, the Amazing Grace Chorus is going to come and get us all to sing together with them. It's a chorus composed of people who have dementia and their caregivers. So Jim just became the person that set it all up for us in terms of talking about the brain. And he just happens to be my son. I've taught him everything I know, which is not exactly the same thing as everything he knows. He graduated from Boston College with a degree in psychology. He did a PhD degree at Loyola University in Chicago in clinical psychology, and from there went to Yale for an internship and to Hartford Hospital. Help me, Jim. Institute for Living for a residency in neuropsychology. And he has been in private practice since he finished his fellowship and has, with a partner, grown a quite large practice where they take care of people with all kinds of brain issues, which Jim will talk to us about today. So enjoy the ride. I think you'll find it most interesting. And thank you all for coming, but before I do that, I have to say thank you to the whole huge number of people and teams that rearranged this dining room because our usual room was unavailable. And they really went beyond the call of duty. Thank you, thank you, thank you. Jim Pierce.
I don't know how often a speaker starts by saying, thanks, Mom. But thanks, Mom.
You're welcome, son.
And thanks to all of you for coming today. I'm very happy to be here with you today to talk about our aging brains, the good, the bad, and everything in between. And there is some of all of that. So we're going to talk about that today. I tried to think about presenting information that would be helpful just in terms of thinking about our own experiences as we get older. And so we're going to talk some about that and some about some disease states and also what maybe we can do about that. What are some things that help us age well? So as Joanne mentioned, I'm a clinical neuropsychologist, and neuropsychologists are a greedy bunch, so we like to evaluate and treat pretty much anybody who has a brain. So, we work with folks who have developmental conditions like autism, attention deficit hyperactivity disorder, learning disorders, and also a wide range of illnesses and injuries that affect the brain. Traumatic brain injury, stroke, multiple sclerosis, Alzheimer's disease, and so on. So it is a fascinating and very humbling profession to be able to work with people about something as important and as intimate as our brain and our brain function. So I want to just set an agenda a little bit, but before I do that, I want to invite you please to ask questions along the way. If I'm unclear about something, or if you'd like me to elaborate on something, please let me know, and I'll be happy to take questions. I'm also going to stick around for a while after we're done, and I'm more than happy to talk with people, to answer questions, and so on. So in terms of our agenda, what I'd like to do is we're going to start talking just a little bit about the brain, provide a very basic overview of the brain itself. We'll talk about what does normal aging look like, what do some not so normal aging and mild cognitive impairment issues look like. We can talk about diagnostic issues, what to do and what not to do, and then we'll talk about dementia and Alzheimer's disease and their treatment, and a fascinating group of folks called super agers. I'll tell you who those folks are and what we can learn from them. A big caveat, this is very important. We all have glitches. As my mom alluded to, we've all had that experience of, oh my gosh, I can't think of that person's name. You walk up to your neighbor to say hi and you can't think of her first name. Oh my gosh, I lost my car keys. So we all have glitches. No diagnoses will be made today. So you're all going to find when we talk about this, oh my God, I do that. I must have X, Y, or Z. So we all do that. Don't do that. If you are concerned, it's good to talk with family and your healthcare provider, but please don't jump to conclusions. This is meant to be educational, informative, hopefully fun, but it's not meant to provide a diagnosis or treatment recommendations for anybody. When we think about aging, it's possible to do it very well and very happily. And as I visit my mom here, I think a lot of you are doing just that. And I think today you'll find I'm somewhat preaching to the choir, which I'm very happy about. But you can do it, and you should be willing to brag a little bit, perhaps. And so my dad's mom, my Grandma B, was wont to do that. She was an avid bridge and sheep's head player. And when she was about 95, we were playing sheep's head at my mom and dad's condo, and I had badly misplayed a hand. And Grandma B took no mercy. She wiped the table with me for that hand. And then as we were reshuffling the cards, she replayed the hand to me and then patted me on the hand and said, "It's important to count the trump, Jimbo." Thanks a lot, Grandma. So live well and be willing to take some pride and some happiness. Say, good old Bill and Joanne. My high school friends started calling my mom and dad that when we would go repeatedly to their house at Wildcat Lake in Boulder Junction. At first unbeknownst to them, and then I think as a badge of honor. So I'm going to dedicate this to my mom and dad, who wrote the textbook on living with Alzheimer's disease with love and with grace. Okay, our amazing brain, and it is amazing. It's astonishing what our brains do for us, and it does it so easily and with such alacrity that we're often unaware of it, or we don't even think about it. But consider for a moment just a few cognitive things. Reasoning and problem solving, how to deal with a dilemma, our ability to learn, our use of language and communication skills, visual spatial abilities, executive skills like organizing and planning. So you are here today. What does that mean about planning your lunch, planning for things later in the day? If plan A doesn't work, coming to plan B. Academics like reading and math and so on. So these are all cognitive skills that our brain does for us. Our brain also performs sensory and motor functions for us. So this delicious smell of cookies baking in an oven, the visual delight of a sunset, being able to reach out and grab someone, to use dining utensils. Again, we don't think about these things that come fluidly and naturally, but these are things our brain does for us. One thing sometimes people lose sight of, though, is that our brain also is responsible for our behavior, our mood, and our personality. That is also largely biologically derived. It reflects what the brain is doing. And from working with families of survivors of traumatic brain injury, or folks who have had stroke, or even folks who encounter dementia, families seem to be least understanding and least tolerant of changes in personality. We lose sight of that. So after a brain injury, or in the context of dementia, if somebody is apathetic, or no longer affectionate, or irritable and agitated, sometimes we forget sight of the fact that that reflects brain function just as much as the use of language does. But it's important to keep that in mind. So here's the human brain. This is a schematic. The cortex of the brain is the most specialized part of the brain. It's what makes us human. And there are 4 big lobes. And all I want you to recognize from this is that there are different functions that live in different regions of the brain. So in the frontal lobe, this is planning, organization. It's our accelerator. It's what gives us drive and motivation. It's also our brake. It's what allows us to recognize that in church or in the library, I don't shout. That I use profanity sparingly and not in certain situations. So it allows us to accommodate our behavior to what the environment expects. The temporal lobe involves language and memory. Parietal lobe involves visual spatial skills, and the occipital lobe is where visual things are processed. So again, all I want you to think about is that the brain is specialized and different regions are responsible for different behaviors. This is an MRI of the brain. So this is the same orientation as what I just showed you before. This is the front of the person's brain. If this were a live person, they're looking that way. Their nose is right here. The back of the head is here. Here's the MRI. You can actually see the nose. And so this is the frontal lobe that I showed you, the parietal lobe, the occipital lobe, and down here is the cerebellum. And the reason I'm showing you this is it gives us a sense of the connections among different regions of the brain. And what we're realizing now is that the connectivity is what really allows for phenomenal thinking abilities and achievements and accomplishments. It's this connection among all the different regions of the brain. And here is a picture of the brain. Again, it's the same orientation. The front of the brain, here's the cerebellum down here. And in terms of these connections, for example, the cerebellum here, we used to think of it mostly as being responsible for coordinating movements, for balance and walking. But what we realize now is that the cerebellum here, even though it's not located next to the frontal lobe, has intimate connections that go through the brain and influence functions of the frontal lobe of the brain. So again, the notion is that the whole brain has to work together in order to allow us to do all these amazing things that we take for granted. A little bit more about the brain. The brain is not that large. For an average adult, it weighs about 3 pounds, or about 1,400 grams. So for a person who weighs 150 pounds, that's only 2% of their body weight. But think about this. The brain receives 20 to 25% of blood that is circulated by the heart. Only 2% by weight, but it is just a glutton and receives 20 to 25% of blood circulated. That's because of the phenomenal metabolic activity that the brain does. It's constantly working, and it needs great supplies of glucose and oxygen. And there are about 100 billion neurons that make up the brain. So, talking about the blood supply, this is a picture of the vasculature, all the blood vessels that feed the brain. This is an amazing technique where they subtract out the brain tissue itself. Look at that. Doesn't it look like there would be no room for anything else in the skull? It's so dense. But in and around all of these blood vessels is the brain, what we call the parenchyma, the brain tissue itself. So, here's a spoiler alert. I'm going to first take home today is move it and use it or lose it. So at any age, any and all activity helps. So because the brain needs so much blood, because it is so greedy, the better our circulatory system, the better able it is to supply that blood, the better functioning the brain tends to be. There are a lot of additional factors that contribute to that, but we, as best as can, be active, physically, mentally, socially, because that will help with brain health. Now, having said that, sometimes, of course, there are situations that prevent us from being physically active. And any activity does help, however, even just upper extremity movement and so on. So But to the extent that we're able, we want to try to remain active. I mentioned there are 100 billion neurons in the brain. I just wanted to show you a schematic of a single neuron. So these are the cells that do the work. They talk to each other. They allow us to do all the things I mentioned earlier in terms of cognition and sensation and so on. So communication comes in, and these dendrites receive the communication. If it is sufficiently intense, it causes an electrical and chemical change right here. It scoops down the axon here to the terminal, and then it dumps a chemical called a neurotransmitter into the space. And if that lines up with the next cell and is enough, boom, it fires and the communication goes on. So, again, I mentioned the brain is astonishing. Everything we do boils down to yes or no. Did the neuron fire or did it not fire? And how are they communicating to each other? Here's another schematic of this process. This cell is talking to this cell, so here's a neuron, and here's a neuron. The communication comes down, and it dumps the neurotransmitter, and wakes up this cell, and away we go. Here's another schematic of it. It just shows you the neurotransmitter gets released, and the neuron either fires or it doesn't. When it goes well, it goes very well. When it doesn't go very well, this is what happens. So there's some scientists, and it says, it's time we face reality, my friends. We're not exactly rocket scientists. You can see the rocket again. So, neurons don't always fire like we want them to. Years ago, Joe Theismann, who played football for the Washington now Commanders, was on a Monday night broadcast, and they were talking about the brain and how smart football players were, and he interjected, well, football players aren't geniuses. A genius is somebody like Norman Einstein. Sorry, Joe, good try. Swing and a miss. So, with apologies to Professor Einstein, Joe may have been behaving a little bit more like Homer Simpson. Okay. So stepping aside from the brain itself, I want to introduce a topic called reciprocal determinism. This is a term that was coined by a psychologist decades ago named Albert Bandura, and his idea was basically this, that we have a person with a brain, we have an environment in which that person functions, and then there's behavior. And these factors are not fixed, or they impact each other, they change each other, sometimes for better, sometimes for worse. And so if a person behaves in a certain way, that might change their environment, which might impact their behavior, which in turn can further impact their brain through learning or reinforcement. So the brain and the environment impact each other. The environment can shape the brain. Let me give you an example. Stress is not by itself a bad thing, but when stress is unremitting and uncontrollable, it causes the release of a chemical cortisol, which causes brain damage. So tragically, we know that children who are abused, this process literally changes the structures of the brain and the functions of the brain as they develop. An example of how the environment shapes the brain. Conversely, if there is optimal nurture and stimulation, structure, discipline, care, that causes synaptic density. This happens beautifully and lots of times. So that causes enhanced brain function. So the brain also, however, shapes the environment. So let me give you an example of an impaired child who is impulsive, unruly, insulting, disruptive. Think about in the classroom that brain causing behavioral discontrol shapes the environment. Students don't like him, he's ostracized, he doesn't get invited to play at recess, teachers are constantly reprimanding him. So this process, this interactive creation of brain and environment continues throughout the entirety of our lives. It doesn't change. Like a lot of things in terms of brain function, we need to look for the Goldilocks sweet spot, just the right amount. This is true for arousal, stress or anxiety. So if you think about this axis being level of functioning, here's our stress or anxiety. None, not good. No motivation, we don't tend to do a whole lot. Too much, we're overwhelmed, paralyzed, inefficient. Just the right amount, you can see, so this is called a curvilinear relationship, where just the right amount causes the optimal level of functioning. So as we think about our brain health, especially as we get older, we really want to achieve the Goldilocks sweet spot here. Being in an environment that's devoid of other people, challenges, stimulation, not good. We don't function as well. It harms our brains, quite literally. Being in an environment that is too chaotic, too stressful, bombarding us, that also is not good. We need to look for the sweet spot. And I'll tell you, having visited my mom here several times, I think this place is an excellent example of the sweet spot. We'll talk a little bit more about that later. So, think about this. Our brains create. It is not a passive organism. Our brain is constantly synthesizing, integrating, and importantly, making predictions. So I want to take thirst as an example. We've all had the sensation of being thirsty, and then drinking, and then fairly quickly the sensation of thirst goes away. Except the hypothalamus, a structure in the brain that tells us when we're thirsty, doesn't physiologically get information that we're now adequately hydrated for 20 minutes after we take a drink. There's between the time we drink and the time, what's called osmolality, basically, the brain's hydrated, all is good. It takes about 20 minutes, but our sensation of thirst goes away very quickly. Well, why is that? That's because the brain has made a prediction, and that information gets to the rest of the body so that we no longer feel thirsty. Same thing for danger or adventure. We process and we predict. If I'm in the woods and I see something in the peripheral vision, and I think it's my wife hiking with me, I may have a set of emotions and expectations and turn towards her and smile. If in my peripheral vision I think it might be a bear, I might have a very different reaction. And that happens instantaneously because the brain is taking snippets of information and making a prediction. You're about to get a hug or you're about to get mauled. Very different danger versus adventure. When my wife's mad at me, sometimes she might want to maul me, but she usually doesn't. The same is true for reading. We think about reading as being a skill that happens in the left hemisphere of the brain where language happens attaching sounds to symbols. But the brain predicts and it generalizes. So, for example, I don't say anything out loud, but can I see by a show of hands, can anybody tell me what word that is? That is an English word that I have on the screen there. Now, if I tell you that it's an animal, by a show of hands, does that help at all? You can hear it. What is it? It's an elephant, yes. So, how can you read that as elephant? That looks nothing like the English language because your brain predicted and said, well, when I see the word elephant, this is what it looks like and so on. So our brains create. That doesn't say elephant, but our brain can create and tell us, well, that's what that word says. So our brains create. It's not stimulus response. It's stimulus and then assess, integrate, recall, compare, model, predict, and then respond. And then assess and analyze and adjust. Did that response work? Let's get more information. So just looking at it, I didn't know. Now I know it's an animal. The brain does a whole other series of calculations, comparisons, computations, and boom, we can read. Okay. So, when I was a kid, I used to read Mad Magazine, and this is Alfred E. Newman, who was often on the cover, and his catchphrase was, what, me worry? And so I think that's a question we all have, right? So we've got these amazing brains. We know a little bit about how they work. They're very active, but things sometimes don't go the way we would like. And so the question is, what, should I worry? Well, the answer is maybe, but maybe not. So let's talk a little bit about normal aging. unfortunately, there are inevitably age-associated changes in our cognition. That's just a given. And they happen, or they begin very early in life, in the 4th decade. So when neuropsychologists give tests, for example, if the examinee is 70 years old, that person gets compared to other 70-year-old people, not to somebody who's 30 years old. They would look quite impaired if we compared them to a younger person, on some but not all tests. Vocabulary, for example, is very resilient. It doesn't change much with age, so it's certain areas of cognition. These age-associated changes are frustrating, but they're benign, meaning that they do not reflect a pathologic disease state. They do reflect changes in the brain, but as my college roommate would say, it's a leaky boat, but at least we're all in it together. So we're all changing. And a big tip about normal aging is that we're able to compensate. So these changes tend not to interfere with our day-to-day functioning. We might learn little tricks or compensatory strategies. We might take a little bit longer, but we still are able to get done what we want to get done. So years ago, I evaluated a man who came in. He was convinced he had Alzheimer's disease. He was just in a panic. And I did the evaluation, and his cognition was tremendously robust. He scored beautifully on all the tests. And so I was giving him feedback, and I said, now, I'm not dismissing your concerns at all, and continue to pay attention, you and your wife, to how you're doing. But the data tell us that you're doing extremely well. What you're experiencing are normal age-associated changes. And I loved his response. Yeah, but it still sucks. And he wasn't wrong. Sometimes it does suck. So why does this happen? Well, there are changes to our brain that occur over the years as we get older. One of these is atrophy. That simply means that brain tissue dies and our brains shrink. It happens normally. There are vascular changes. If you think back to that picture I showed you of all the blood vessels in the brain, some of the blood vessels are very small and penetrate deeply in the brain to supply blood to structures deeper in the brain. Those blood vessels normally, as a part of aging, tend to get plugged. And so there are teeny tiny, what are actually little strokes that happen. It's called microvascular ischemic disease. It just means microvascular, very small blood vessels that are causing teeny tiny strokes. And for most people, that's asymptomatic. We don't even know it's happening. So if somebody came to autopsy and the brain were examined, the neuropathologists usually say there's age-associated white matter change. There are vascular changes that are age-associated. Now, if that happens to an extent that is excessive, then that process starts to become symptomatic. People begin to have problems with their thinking abilities, with active retrieval of information, and so on. And especially when there are problems with poorly treated or undiagnosed diabetes, high blood pressure, high cholesterol, and the other big one is cigarette smoking. So those are the factors. So since many of those have to contend with those issues, it's really important to cooperate very carefully with their healthcare provider so that those risk factors for vascular changes are mitigated as much as possible. What this does, the vascular changes, is interferes with the connectivity. People with these white matter changes describe an inefficient, sluggish, slow brain. That's because the connections that I was described here that are so important have been disrupted. And so the cognitive changes that happen, again, these are normal. This is part of the normal aging process. Our reduced speed, it takes us longer. So calculating a tip at the dinner table used to have boom, boom. So 10% is $5 and another whatever is $2 more. And now it's like, wait a minute, 10% is it? It takes us longer to do that. We have word finding inefficiencies. So anybody in this room not had the experience where there's a word you wanted to use and doggone it just wouldn't come to you? Anybody not have that experience? Yeah, most of I see people laughing and nodding their heads. It's ubiquitous. It happens all the time to all of us. And although it can be frustrating, it's normal. So where's my whatchamacallit? Well, it's in your Hoosier-thanger right there. My wife and I, so we're 60, and we're sometimes watching TV and joke that we're happy that we're both sitting there because between the two of us, we think you have one fully functioning brain. So, what's that actor's name? I can't remember. It was in that movie. Oh, that's right. No, there you go. So, our brains are less efficient in terms of recall. Again, sometimes it comes to us later. And so, you didn't get it when you were on the couch chatting, and then later doing laundry. Oh my God, now I remember. I know exactly what it was. And we can be a little more forgetful. Again, these are frustrating, but normal. Have any of you played the coffee cup game? Again, Susan and I like playing this game. We do it Saturday mornings. We get up, pour a cup of coffee, and then she goes out to garden, and I go down the driveway to get the newspaper, and then I have to check my schedule, and then we're fussing around, and periodically we say to each other, hey, have you seen my coffee cup? We spend the rest of the day hunting around for a cup of coffee that we've been toting around the house. You put it down, you get busy, you get distracted. So another example of normal age-associated change. In neuropsychology, we have a very important axiom, and it is that if you have seen one patient, you have seen one patient. And this schematic, it was made for patients with traumatic brain injury, but we can easily substitute in here any number of neurologic conditions. And all I want you to take away from this is how busy the slide is, right? And so these are the endpoint symptoms or difficulties, but notice the pathologic condition, traumatic brain injury, stroke, Alzheimer's disease, is only one box. There are pre-injury factors. What is your medical health like? How much education do you have? Do you exercise? Are you socially engaged? Are you a musician? All kinds of pre-injury factors. Then there are psychosocial factors. With whom do you live? Are you in a supportive relationship? Do you have access to the theater? All those sorts of things. Because all of these factors will impact our cognition, our emotional functioning, how we behave, and physical manifestations as well. Remember, at the very beginning I said that our brains do everything for us. What we think, what we feel, how we behave, how we interact with the world. It's all brain mediated. So when we think about getting older and we think about pathologic conditions like Alzheimer's disease, it's really important to keep in mind that if you've seen one patient, you have seen one patient. We are all individuals and unique, and so we want to be very humble and careful and cautious in making diagnoses. So, let's talk about that. Diagnostic problems. One of the most common frustrations I have is diagnoses that are made in a lackadaisical fashion. So, I will see records or talk to a patient or to families, and they've been told that their healthcare provider said, well, I see this all the time. It seems like, this really feels like, or I'm not sure, but it sure looks like. And what is happening here is a phenomenon called assumed similarity. It's very dangerous. And I think all of us can be prone to that as well, that we assume that our experience, our history, our struggles are going to be similar to other people. Now, indeed, some of the time that is the case. So we've just talked about the word retrieval inefficiency that we all have had, and that it can be frustrating. But when it comes to making a diagnosis, to deciding, is this normal aging? And I'm just frustrated, but I can deal with it. Or is there something a little more alarming that requires medical attention? That's where we want to assiduously avoid assumed similarity. It's really important. Another problem in diagnosis is improper extrapolation. So, oh, you forgot your car keys? I'll bet you have Alzheimer's disease. Or someone gets a bonk on the head, or even a real concussion, and they're told they have chronic traumatic encephalopathy, or CTE. Or someone's in a motor vehicle accident, and then they're nervous about getting in the car, understandably so. And somebody says, oh, I think you have PTSD. So each of these conditions, Alzheimer's disease, chronic traumatic encephalopathy, and post-traumatic stress disorder, PTSD, have a set of very well-established diagnostic criteria. And to conclude that someone has one of these conditions, we have to, in a very thorough way, establish that the diagnostic criteria have been met. And if they haven't, we should not be applying that diagnosis. We might talk about features of it or concerns, but we need to be careful about making a diagnosis. So the diagnostic process requires humility and ongoing assessment, being open to new data and information, listening to the patient and the family. This is, of course, extremely important, especially in the early stages of changes, where patients and family members often know that something is different, something is wrong, and we can't yet detect it with some of our diagnostic procedures. So being open to, in response to listening to the patient and the family, being open to new data and to ongoing assessment, reconsidering our initial impressions. So diagnosis is an ongoing process because human beings are complex and fluid. We're never the same person 2 days in a row. Another concern is failing to consider or assess premorbid function. So if you're going to say that someone has had an abnormal change in their thinking ability that rises to the level of perhaps a diagnosis or is clearly pathological and not part of the normal aging process, you need to know something about who this person was prior to the onset of this concern. And so here's an example. Let's say we give an individual a math test and she scores at the 66th percentile. That's a pretty good score. But what if you then find out that she is an aeronautical engineer? That score stinks. We do not want her scoring at the 66th percentile. On the other hand, a person might score at the 24th percentile, and we say, that's kind of low. I'm a little concerned about that score. But what if this person never graduated from high school? So when we consider how to understand our day-to-day experiences, where things are going beautifully, what concerns we have, it's important to keep in mind these factors, still we call premorbid factors in terms of understanding the individual. This is not just a semantic issue. There are very real and quite serious reasons for being attentive to the diagnostic process. If we make a wrong diagnosis, we can provide inappropriate treatment. So, in Alzheimer's disease, a common early symptom is apathy. People stop engaging in activities that used to be very enjoyable to them. What other condition is associated with that? And can anybody tell me? Depression, exactly. So we might say, he stopped going to the theater and isn't interested in the bowling league anymore. We'll put him on an antidepressant medication. He must be depressed. Well, that's not an unreasonable hypothesis. It's a good hypothesis. But if you stop there, we've provided inappropriate treatment if indeed that person turns out not to be depressed. Feedback that is based on inaccurate diagnosis can cause psychological distress and lifestyle changes that might be unwarranted. When people come to see me, they're often wondering, can I continue working? Can I drive? Can I live alone? Should I go to California to see my grandkids? And if somebody has significant cognitive impairments, we might give them advice based on that. And if we're wrong, we can cause distress. First of all, oh my gosh, I knew it. I have Alzheimer's disease. I have some form of dementia, and I'm done. I'm just going to get under the covers, and that's all she wrote. We want to avoid doing that. Similarly, we can prevent the identification and treatment of conditions that are present. If the diagnostic process stops and it's wrong, we might fail to identify conditions, especially conditions that are treatable, and that's obviously not a good thing. So many causes of changes in our thinking abilities are treatable. So we want to be very careful and very thorough in exploring that possibility. So what does the process look like then? If I have a concern, a good place to start is primary care provider, especially if there's an established, long-standing relationship. Because the primary care provider can do blood work, other laboratory studies, and look for treatable causes of cognitive difficulties. And there are many. Vitamin deficiencies, anemia. It's a lengthy list of things that can be easily remedied that might correct the cognitive difficulties. Many of us, by the time we get to our 60s, 70s, 80s, are on numerous medications. Well, many medications have cognitive side effects, especially psychiatric or what we call psychotropic medications. Benzodiazepines like Valium, Ativan, Xanax are quite ruinous for attention and memory. So, but lots of other medications are as well, including medications for headaches and sleep and high blood pressure and so on. So you want to be working with your primary care provider to consider that possibility. Neurologists can be very helpful in helping explore other possibilities and getting imaging of the brain. A mental health consult can be very helpful, brain imaging, and then neuropsychological evaluation, about which I'll talk a little bit more. So all I want you to take home from this slide is look at the list. Whoops. It's a lengthy list. This is not a simple slam dunk process. If we're concerned about cognition, we should do something about it. I'm not saying ignore it, but we want to be thorough and careful about what we do. Another issue to keep in mind is that neuropsychological symptoms are nonspecific. Problems with attention, memory, learning, they happen in all kinds of conditions, including perfectly normal, healthy individuals. And if we fail to consider this non-specificity, we might conclude that normal glitches are due to some type of pathologic process. And I'm going to show you some information that might make you say, whatever you do, don't go to college in terms of cognitive complaints. So headaches, for example, are a common manifestation of neurologic problem, but also 57% of university students who were polled complained of them. Community volunteers, outpatients, depressed patients, headaches are common. Look at problems of concentration, 82% of university students, memory, 47% as well. So all I want you to take away from this is that our subjective experience of fluctuations in our cognitive functioning, of symptoms, especially if they come and go, may simply reflect the normal variability and might not be an ominous sign. And then we talked a little bit about depression earlier, and so these are some items from depression scales. So these are questionnaires we give to patients when there's a concern about depression, and we're not looking for neurologic disease. So folks who presumably don't have illness or injury affecting the brain that's neurologic. And the kinds of things that we ask about are true or false. My memory is worse than most people I know. I have more trouble concentrating than in the past. I have great difficulty making decisions. I certainly have trouble focusing my thoughts. You can see these all sound like complaints that a person with Alzheimer's disease would make. And indeed, that is the case. That's exactly the point, is that based on the subjective experience of the complaints, we don't know what's going on here. So somebody with significant depression who has no neurologic illness at all is very likely to complain of at least some of them, and perhaps all of them. So we talked about normal aging, we talked about the diagnostic process, not jumping to conclusions, but we want to recognize that there is a condition where aging is not so normal, unfortunately. We call this mild cognitive impairment, or MCI. MCI sits right between normal functioning and the earliest stages of dementia. So it is not normal, but it also is not dementia. These folks have cognitive complaints, usually, but not always, including memory problems. But cognitive screening test is usually normal. So the mini mental status examination, or MMSE, is often given by physicians, PAs, APRNs in primary care offices. And if you can tell me the date, who is president, if you can remember 3 words after a few minutes, and write a sentence and do a simple drawing, you're going to come out normal on this test. So it's a good screening measure, but obviously for people who are well educated and thriving and have had professions and taking care of families, it's not adequate to say, yeah, you're good to go. You scored well on MMC. Importantly, in MCI, there can be a decline on more sensitive tests of cognition. In fact, that's what we expect to see. A small but measurable decline. But activities of daily living, ADLs, or other important aspects of day-to-day functioning are typically not significantly affected. Independence is preserved. So people at this level likely need more time. They've begun to use more often compensatory strategies, sticky notes all over the place, reminders on the phone, having my neighbor call me to remind me, those sorts of things. But they're able to function fairly well, and these people are not demented. They do not meet the criteria for dementia. There are lots of causes of MCI. One is prodromal Alzheimer's. Prodromal simply means that these are the initial signs and harbingers that Alzheimer's is coming down the pipe. So that does happen. But as we discussed earlier, medical illness can cause this, depression and other psychiatric illnesses, medication side effects, substance abuse, and sleep impairment, and then just getting old. And I put parenthetically, sorry about that, but that's the cruel reality of it as well. The biggest risk factor for MCI and for Alzheimer's disease is getting old. There you have it. We don't have any way of preventing it, but as we're going to talk in a little bit, happily, we do now have some medications that can slow it down. So, but just hanging around, living life, enjoying things, that's the biggest risk factor for MCI. I want to mention just a little bit more on sleep impairment. Sleep is extremely important for preserving brain health. There is a condition called obstructive sleep apnea that is very common. And I can't tell you, it's dozens and dozens of times I've had patients in my office, and even though I'm not a physician or a sleep medicine specialist or a pulmonologist, typically the person is a little heavy and they complain about snoring loudly, tired during the day, I'm forgetful, I'm inattentive. Send them off to the primary care doctor. Please ask your doctor to assess for sleep apnea. And they come back, the diagnosis was made, they got put on CPAP, and by the way, there are newer machines that are much more comfortable, much better tolerated, and they say it's like someone turned this light switch on. It's just a game changer. So sleep is really, really important. So we have normal aging. It can be frustrating, it can be discouraging, but it's not alarming. We're able to cope with it and still enjoy our lives and our brains and all that our amazing brains can do for us. We have MCI. Things are not normal any longer, but not demented, still generally doing fairly well. And then further down the continuum, we have dementia. Dementia is a syndrome. What that means is it's a descriptive label. Dementia itself is not a diagnosis. And dementia can be caused by many different kinds of illnesses. Alzheimer's disease is the most common cause of dementia, but there are many other conditions that can cause it. So what is dementia? It's acquired cognitive impairment with deficits in memory, language, visual spatial skills, abstraction, mathematics, judgment, and also sometimes impacting personality, mood, and behavior. Now the impairments do interfere with important and basic aspects of adaptive functioning, and there's a loss of independence and effectiveness in day-to-day functioning. There are some interesting data on conversion rates going from MCI to Alzheimer's disease. And so we can look at controls versus, so folks who have MCI, if we look at them over 4 years, we see that they are at increased risk. So this orange bar are folks, so let me back up. Initially, all MCI folks, nobody has Alzheimer's disease. A year later, some people have Alzheimer's disease. 2 years later, 3 years later, 4 years later. So as I said, for some people with MCI, but not everybody, remember, some MCI can be treated. We can make it completely better. But for some folks, it is the sign that they're going to be in this group who develop Alzheimer's disease. Compared to the controls, so these folks, at the initial study, they're normal. And look how much less likely it is for this group to develop Alzheimer's disease. So I don't show you those data to be alarmist, but again, to just remind you that if you're having difficulties or frustrations, don't ignore them, but recognize that there are lots of situations, conditions, factors that may be influencing you, and we want to be thorough in understanding all of that so that we don't miss an opportunity to intervene and treat and perhaps resolve or at least diminish those difficulties. Alzheimer's disease is here to stay, and you can see that between 1995 and 2050, the incidence, the number of people with Alzheimer's disease in the United States is going to increase rather dramatically. So this is a health emergency. Unhappily, for decades, Alzheimer's disease didn't receive anywhere near the attention, the funding, the research that it deserved. And now we're kind of paying the piper. We're going to talk a little bit about medications in just a little bit. But it's a huge problem. Alzheimer's disease, for example, each year takes the lives of more people than patients with breast cancer and prostate cancer combined. So it is a very important health issue, and it's not going away.
Jim?
Yeah.
Why is there this dramatic increase? Is it the numbers of aging population, or is it external factors?
Excellent question. So the question was, why is this? Why are we seeing an increase in the numbers of patients with Alzheimer's disease? The short answer is we don't know, but one very strong hypothesis is that because people are living longer, more people are surviving to develop Alzheimer's disease. So think about the treatments available now and early detection and identification of diabetes, high blood pressure, hypercholesterolemia, better attention to mental health issues, even though, don't get me started on that, that still is in many regards a catastrophe. People are living longer because of medical interventions and treatments and mental health interventions and treatment. And some of these people would have died before the disease expressed itself. So, again, the biggest risk factor for Alzheimer's disease is living a long life. And so that's probably at least partially explanatory for this graph. Okay. So, I mentioned earlier there are many different causes for dementia, Alzheimer's disease being the most common, but cerebrovascular disease. You can get dementia with Alzheimer's from multiple teeny tiny strokes. People at risk for this, again, are people who have diabetes, high blood pressure, cigarette smokers, Parkinson's disease, traumatic brain injury, Lewy body dementia, and mixed pathology. Mixed pathology, actually, is more common than pure Alzheimer's disease. Most patients with Alzheimer's disease, for example, also have some vascular pathology. Most of us do. I would say that probably the vast majority of us sitting in this room right now, if we had a really a 3 Tesla high-intense MRI of the brain, it would detect these changes. That's unfortunate, it's a bummer, they're there, but as I said, most of us have it and we don't even know about it, we walk around. So the pathology, what's causing dementia for many people is more than one condition. This is a busy slide. Here's all I want you to know about the pathophysiology. There's protein in the brain. There's 2 types, beta amyloid and tau. This is good. The brain needs it. However, in some people, the brain's ability to clear the protein and to excrete it is abnormal. And so it tends to build up. It's like throwing clumps of clay around inside the brain. And this interferes with and injures the neurons. Remember, the neurons are the individual cells that do all the work for us in the brain. That leads to neurodegeneration, which basically means the death of brain neurons. And this abnormal process happens in regions that are involved with memory, the hippocampus, the temporal lobe in particular. So it makes sense. The most common early signs of Alzheimer's disease are some subtle problems with language and memory problems, especially forgetting, repeating oneself. Those are the red flags. That's how Alzheimer's disease usually, but not always. Remember, if you've seen one patient, you've seen one patient. So I'm generalizing. But, so it makes sense that those are the early clinical manifestations because that's where the pathology is happening. The hippocampus, very much involved with memory, the temporal lobe, language and memory, and the parietal lobe is also visual spatial kinds of abilities. Now, this next point I'm going to make is both cause for optimism and consternation. The pathology is present years before clinical symptoms emerge. So these changes are starting typically decades before the individual who has the disease begins to notice changes. So that's cause for consternation because, oh my gosh, what do we do? But it's also cause for hope and optimism because now that we know that, we can look for ways of detecting it earlier and perhaps intervening sooner. I'm going to show you just a little bit about some of the diagnostic procedures for Alzheimer's disease. So this is a PET scan. It's a positron emission tomography scan. Basically, it's a measure of the metabolic activity of the brain. How active is the brain? And this is a normal brain. And on this kind of study, this methodology, bright is good. Blue is inactive or hypoactive, but brightness is good. And notice on the outside of the skull, this is the cerebral cortex. This is our computer. We want to see lots of bright colors at in the cortex, and indeed in this individual you do. This is actually dark because it's picking up what's called cerebrospinal fluid. So there are rooms in the brain called ventricles. They're filled with a clear liquid called cerebrospinal fluid. That provides structure to the brain, and it also cushions and supports the brain. And so since it's not active, because there are no neurons in the cerebrospinal fluid, it's blue. Now here is a PET scan. This is an Alzheimer's patient. Now notice along the edges here where there are none of the wonderful orange and yellows. And these structures are occipital cortex, and these are structures deeper in the brain, mostly involved with movement and kind of relay stations. But the supercomputer is dark and quiet. And you can see normal and Alzheimer's patient. I mentioned earlier that this abnormal protein that gums up the works, it causes neurodegeneration, which means atrophy. So the brain cells die and the brain gets smaller. And here's an example. So this is an MRI. So we're looking, imagine, standing here, we're looking this way. So going back to the front of the person's brain, I mentioned earlier there are the ventricles in the brain. Here these are. And they're dark because it's filled with that cerebrospinal fluid. And then we can see the folds here are called the gyri, and the dark spaces, the spaces between them are called sulci. We refer to these as the sulcus spaces. And in a healthy individual, what you want to see is fairly tight folds or gyri and normal-sized ventricles. There are additional ventricles down here. Now here's an Alzheimer's patient. Notice a dramatic increase in the size of the ventricles from healthy to Alzheimer's patient. Also, notice the increased size. If you look in the front of the brain, you see here big spaces, much smaller here, and even more dramatic in the temporal lobe, which again I said is where language and memory lives. Look at this massive atrophic space here compared to the healthy temporal lobe here. Now, early in the disease, MRIs and CAT scans are almost always normal. It's not until the disease has progressed a while and that you start to see these kinds of changes. However, so, okay, if that's true, Jim, then why would we get an MRI as part of a workup if we're wondering, boy, does this poor person have Alzheimer's disease? A couple reasons. One is we want to know, is there something else that could be causing their problems? Maybe they have a condition called normal pressure hydrocephalus, which is too much fluid that pushes on the brain and causes symptoms. Maybe they have a tumor. Maybe they've had a stroke or an accumulation of strokes. Or maybe we find nothing, but now we have a baseline to compare a year, 3 years down the road to see how things are changing. I mentioned earlier that the pathology of Alzheimer's disease starts long before a person becomes symptomatic. And until just recently, we had really no way of identifying that. So the people weren't symptomatic, so we weren't doing studies on them to see, but the disease process was happening. And then by the time they became symptomatic, in many cases it was kind of too late. Fortunately, that's not so much the case as it used to. We're trending in the right direction. So we now have what are called biomarkers. So one is the PET scan. I showed you the PET scan earlier. Let me back up a second. Importantly, we can do these while people are still alive. So Alzheimer's used to be a definitive diagnosis only made after death, when they would look at the brain and they would search for the characteristic pathology, these plaques and tangles, and probably also some vascular changes that were causing the symptoms. And so PET scans, people can have these done to look for that hyperactivity. There are blood tests now that detect downstream evidence of these abnormal protein deposits. We can examine the cerebrospinal fluid. This is more invasive because it requires a spinal tap. They insert a needle into the lumbar spinal column and extract the cerebrospinal fluid and then examine it. So it's not a happy procedure, and there's a potential complication called spinal headache. So if we can, it's nice to avoid those. And now there are some blood tests. These are still kind of brand new. People are still getting used to them, but it provides additional data that we can integrate into all of the other data we have to try to determine what's going on. There's also genetic testing available. This will not tell you if you have Alzheimer's disease or not, but this gene, the ApoE4 gene, is a risk factor for Alzheimer's disease. So people who have what are called both alleles, that is, they're strongly positive for this gene, they have increased risk of Alzheimer's disease. People who don't have this gene at all are at lower risk, and if you have only one, but not both alleles, you're sort of in the middle. So it's quite impressive that we would see that gradation based on this gene here. And this can be obtained through a simple blood test. So we're moving towards a more definitive diagnosis that's not only post-mortem any longer. What this does is provide lots of additional data that we can integrate into our diagnostic assessment to try to be as precise as possible. Earlier I said that there are significant problems with making a misdiagnosis, but we also don't want to, so if we make an incorrect diagnosis, that's bad. But if we don't make a diagnosis that is there, now you're fine, there's nothing here, that's also bad as well. Did you have a question? Yeah.
Yeah, if you have a relative who passed away from Alzheimer's, is it logical or beneficial to have the genetic testing at any particular age, or should you have it at all, or should you forget about it? I don't know.
So the question was, if you have a biologic relative, does it make sense to go get tested for that gene, or should you not do it? So that's a very important and complex question. There is no right or wrong answer. So again, in consultation with a healthcare provider and family, the question to ask is, if I test positive, if I have both alleles for ApoE4, what would I do? How would that change my life, my decision making, and so on? So if your decision is, well, here's a list of 6 things I would do that I think would really be good things, but I'd be bummed, I'd be worried more and anxious that calculus is very difficult. So it's a very complex personal, medical, and ethical question. And again, not something to be taken lightly, obviously. I think when the equation might tilt a little bit more towards going ahead and getting that testing is a parent had Alzheimer's disease diagnosed at age 60, because we know that that kind of early onset has a higher genetic contribution. So now I'm at risk just because my parent was 60, and I'm diabetic and 30 pounds overweight, and having some clear problems with my cognition. I've talked to my kids and my wife, and I'm forgetful and repeating myself. So then the question is, do you really want to try to get more definitive information? That might be a scenario where someone would say, yeah, it's a simple blood test by Athena, let's get the APA forward and find out. So if you've seen one patient, you've seen one patient. So please keep that in mind. These are really important medical, personal, ethical questions. Having this information, I think, can be helpful in thinking about that and having discussions with your healthcare provider and with family. Yeah. Yes, sir.
These markers, biomarkers, I think are for Alzheimer's. Are they useful for other kinds of cognitive issues, for example, with Parkinson's?
So the question is, these biomarkers, are they also useful for other neurological conditions such as Parkinson's disease? Not these specifically, however, there is a scan for Parkinson's, for example, called the DAC scan, that is highly sensitive and specific. So Parkinson's disease results from deterioration of the substantia nigra, structures deep in the brain that create a substance called dopamine. And we need dopamine for pleasure, but we also need it for movement. And so this scan also will detect changes in the density and the functionality of the substantia nigra. So that's an example of a biomarker, but specific to Parkinson's disease. So if these were negative and somebody still there was really compelling evidence that there are some problems with their cognition and their functionality, then we're going to look for other diagnostic entities, and that might be one. You're welcome. Okay, so again, I just want to review this again because it's obviously these issues come up and some of the questions have alluded to this. So we have a subjective concern, the patient and the family. What do we do? Good place to start is primary care, perhaps neurology, perhaps mental health professionals, brain imaging, looking for the biomarkers, and this is really important, the clinical history and mental status exam and neuropsychological evaluation to contribute to what's called differential diagnosis. So, what do I mean by that? The clinical neuropsychological evaluation contributes to the diagnosis. It basically is designed to describe functioning. By itself, it typically can't be diagnostic, although we will look for certain patterns. And the goal is to, so once we've described the functioning, identify, implement, and then monitor treatments. Neuropsych evaluations can be very helpful once we have a diagnosis and treatment is in place to help obtain lots and lots of data to assess the effectiveness of the treatment and the progression of disease. So this consists of standardized assessment of cognition, emotional personality functioning, behavior. We want to make inferences about brain-behavior relationships. So given your performance on tests of memory and reasoning and language, what does that, and knowing who you were before this concern emerged, in terms of your education, your professional history, your hobbies, what does this tell us about how your brain is working? It has quantitative aspects, so we do a statistical analysis of the data, comparing to other people of similar age and demographic background, but also qualitative factors, observation and interactions with the individual. So, if somebody does poorly on a puzzle assembly test and is meticulous and careful and thorough, they just can't get it done, that's helpful information. If another patient also has difficulty on it, but they're impulsive, they do it hastily, in a slapdash fashion, those two might get the same scores, the same statistical analysis happens, but those qualitative observations can be helpful in terms of my thinking about, well, these kinds of behaviors are often seen in this type of dementia, frontotemporal dementia, or maybe this person had a head trauma. So I might think differently about the diagnosis as opposed to the person who worked slowly, cautiously, meticulously, but just also couldn't get it done. These evaluations are extensive. They typically take 3 to 4 hours. So think about a typical appointment with your physician. First time appointment might be 45 minutes. After that, it's often 10 to 15 minutes. And we're going to spend 3 to 4 hours with the person. And it often includes family members. I consider it incomplete without input from family, of course, if family are available. And the reason for that is we don't know what we don't know. And oftentimes, when there is a neurologic illness that is impacting brain function, one of the brain functions gets impacted is insight and self-awareness. Neuropsychologists love to have our own vocabulary, so of course we have a word for it. They call it anosognosia. I went to school for a long time. I'm going to have me some really long words. Anosognosia. Simply that means an inability to reflect and to identify where I'm doing well and where I'm doing poorly, what my problems are. And so, because of that, and because that is not an uncommon phenomenon with patients, we want to get information from family members or other significant others, work colleagues, anybody who can comment on their observations. So, we look at the cognitive profile and want to know, does the profile match the pathology? So here's an example of a person who had a stroke but doesn't have Alzheimer's disease. Their intellect is intact, perceptual reasoning is moderately impaired, so puzzle assembly, putting blocks together, making a drawing, looking at matrices and see how they change. Attention is impaired. This is the most common consequence of stroke, regardless of where in the brain it happens. Reasoning is impaired, but verbal fluency and naming are intact. Verbal learning is low average, but retention is intact. And visual learning and retention are impaired. But this person had a stroke in the right hemisphere of the brain that caused these problems. This intact retention verbally, that comes close to ruling out Alzheimer's disease, unless it's the initial contact with the individual. And those one. Rapid forgetting, repeating oneself, those are, again, the kind of the signature, the fingerprints of Alzheimer's disease. So here's a profile that does look like Alzheimer's disease. Good intellect, basic passive attention is intact, verbal fluency is impaired, problem solving is poor, behavior and mood still are normal. Learning was low average, but in a high average intellectual person, that's lower than we want to see, but memory and retention are severely impaired. So a little bit more about memory. In Alzheimer's, long-term and autobiographical memory are intact early in the disease. These last the longest. Learning is inefficient and retention and recall are very poor. Recent memory is impaired. There's lots of repetition and no aha moment when cued. So an Alzheimer's patient starts to tell me a story like, oh, when I was back at Boston College and Doug Flutie was a quarterback there and I lived in this great place and then we go get a cup of coffee and sit down and say, did I ever tell you when I was back at Boston College, Doug Flutie was there, it was a great years and we lived in these little mod apartments and then when I say, well, you just told me that 10 minutes ago. There's no, oh, that's right. I remember. We were sitting over there. There's no recollection of it. This constant repetition without insight or awareness. So often we hear patients say, it can't be Alzheimer's disease. He remembers every camping trip he took as kids. Or someone will say, I can remember things from 50 years ago like it was today. But if you say, what did you have for breakfast? I can't remember. So recent memory, repetition, loss of insight. And then there's often conceptual confusion, loss of independence in daily activities, that loss of independence and effectiveness that I mentioned earlier. I'm going to jump ahead to treatment. Just in inches of time. On the plane here, some gremlins got into my computer and they corrupted my slides about treatment. I can't figure out what happened. Treatment has lagged behind other clinical conditions, sadly. But things are getting better. So for a long time, there were 3 medications: Aricept, Exelon, and Namenda. And what these medications did was they made available drugs here that are being dumped into the space. A drug called, transmitter called acetylcholine. Simply put, the brain has a system for inactivating that, and these drugs deactivated the enzyme that inactivated it. So, let me say that again. You take Aricept, and the neurotransmitter that helps us build memories is allowed to stay active for longer than the normal brain would permit. The problem is, Aricept did nothing to address the disease pathology or progression. It also had, at best, a minimal impact on memory, but it seemed to help with agitation. And it was typically well tolerated, so people took it. But it was kind of like putting a Band-Aid on a hemorrhaging artery, right? It was definitely not what we were looking for. There were lots of supplements. So you might see ad for Prevagen on TV, ginkgo biloba, fatty acids, vitamin E. These all had good theoretical underpinnings. The idea was, well, inflammation is bad for the brain. Excellent blood flow is good for the brain, so let's do things that enhance that. The problem is that there are no good, methodologically sound studies that supported the use of these. There was one Prevagen, but it was funded by the makers of Prevagen, and it was not adequate methodologically. So these are intriguing. I would never say somebody, if you and your doctor decided that you should try these, by all means, there's probably no downside. There is no good empirically sound data that these impact Alzheimer's disease or even our cognition. But there is hope.
Jim?
Yes?
In terms of trying any of those, might there be a beneficial placebo effect? That if you think this is going to work for you, that you may in fact feel like it does?
Yeah, so the question was, could there be an experience of a placebo effect? A placebo effect is when a chemically inert substance can't do anything for your brain or your body. It still seems to exert some beneficial impact. That's called a placebo. It's a well-known phenomenon. If I tell you that this is going to help, there's a chance it might help just because you believe me. And that's why I mentioned methodological problems with the research. They have to be what's called placebo controlled. So you have to have groups in the study who are getting placebo and compare them to the treatment that's actually getting the substance that's being studied, and those studies tended not to include placebo groups. So, like, absolutely, placebo group is incredibly powerful. In fact, I'm a fan of psychotropic medication for many, many people, but I will tell you that there are really compelling data that suggests that placebo effect accounts for at least part of the antidepressant effect of antidepressant medications. So, happily, there is a new drug. It's called lecanemab. And finally, after 500 trials, let that sink in, 500 medications brought to trial, we have one now that does affect the disease pathology, and it's called lecanemab. It slows the progression of the disease by 27%. Yeah, exactly. It works, woohoo! Well, it slows the disease down by 27%. So, it's not a cure. It doesn't prevent Alzheimer's disease, and it does not stop the disease. But it's the first one that shows that it is impacting the disease process. So my hope is that this will serve as a springboard for further research and further applications of this knowledge to develop medications that are even more effective. So, but 27%, that could translate into clinically meaningful improvements in terms of functioning after the diagnosis is made. So it's very good news, not as good as we would hope, but we're on the right track.
Jim,
Yeah,
would that affect the protein buildup, that drug?
precisely. That's
And if-
exactly what it's
And
doing.
would the MRI show improvement?
So, no, unfortunately. What you will see is slower evidence of atrophy on the MRI brain compared to people of similar age and demographic background who aren't taking the medication. That's how we know it's effective. So this research has been very sound methodologically, including placebo-controlled groups, looking at different stages of Alzheimer's disease and so on. Unfortunately, like almost any medication, there are side effects. They're finding that people are having some swelling in the brain and what are called microhemorrhages, teeny tiny little bleeds. So they found that discontinuing the medication and then restarting it seems to address that. And so they don't minimize it, but again, not a solution, but we're heading in the right direction. So, yes, ma'am?
Could you spell the name of that drug?
I had it in my slide, but got Gremlins reading. So it's spelled Lecanamad. Lecanamad. I'm happy to write that down for anybody who's interested. Okay, so finally we have a medication that affects the disease, but it's not a cure, and it won't stop the disease. So what do we do? Well, we need to think about how do we thrive in older age? If we can't stop this doggone disease yet, what do we know about people who thrive in older age? This provides clues to us about things we should be thinking about. And one of the big ones is social connection. So when I come and visit my mom here, and it takes us a half hour to get from the entrance to the elevator, because everybody stops and says, "Hey Joanne, how you doing? How are the grandkids? Good, how are you? Did you watch the Packer game?" I'm so happy to see that, because that is an excellent predictor of not just happiness, but of actually preserving cognition. So if we compare people who don't have this kind of social connection and have similar neurologic backgrounds, people with good social connection do better. Not just happier, although they are happier, their cognition is better. So let that sink in. Social connection is associated with better cognition. Come back to it a little bit. Having purpose in life, family, working, volunteering, clubs. This dynamic continues until we die. So the question is, well, what's causing that? Is the person who has better social engagement doing better because they had a better brain? Or do they have a better brain because they had lots of social engagement? We don't know. And unfortunately, the methodology would be tricky. It'd be hard to get this past an ethics board, say, "Hey, you folks, everybody on this half of the room, sorry, but you get assigned to a social isolation experiment. We'll measure everyone's cognition. You folks go into an isolation chamber. You folks go to the theater, go bowling, art class for you, and then let's measure your cognition." Obviously, I'm being facetious. We can't do that. So we rely on quasi-experimental and observational studies that are imperfect, and that typically provide us only correlational data, and so it's hard to make causal statements. Okay. So we do know, though, that social engagement, there's lots of research on this, helps maintain our thinking abilities and slows cognitive decline, but the evidence does not yet allow the conclusion that social engagement reduces the risk of brain diseases that cause dementia. Probably what's happening is that people are able to cope better with the disease, and it may mitigate or slow down the progression of it for reasons that we don't yet understand. But even if we don't know it, yes, Stephanie.
Just do want to add, though, that social isolation is a causation of dementia, respective for dementia.
So I don't know if you could hear that. What Stephanie said was social isolation can cause dementia and it can exacerbate the process as well. So social engagement is super important. And even if we don't understand fully how it impacts the process, it improves quality of life, it improves the capacity for creative and shared coping and thriving. And again, the flip side of that coin that Stephanie just mentioned, it is associated with thicker brain cortex, implying less atrophy and better memory. So the causality, we just don't know yet. So, superagers, this is the last thing I'll mention to you. There's a multi-center research site based at the University of Chicago. They have people 80 years or older. The oldest participant is 109. And for reasons we don't understand, these people have absurdly good memories. So on memory tests, they score at a level equivalent with people who are in the 50 to 60-year-old group. They have very little cortical atrophy. And so what can we learn from superagers? And here's where I think you all could probably tell me everything I'm about to show you. And here I'm, again, preaching to the choir. One thing I do want to mention is that although this was done in Chicago, they didn't let any Bears fans in once. So again, the directionality is not clear, but it suggests that the environment and psychosocial factors help. Interestingly, 70% of these superagers were smokers, but most quit. We're not going to pack a lucky strike on Camels just because of this. 80% consume alcohol. Yes, good news. So, in moderation, your happy hours and wine with your dinner, have at it. And humor, it was incredibly important to these folks. They find a way to look for humor, to look for happiness. And a female patient of my partner gave a great example of this. She came for an evaluation. Unhappily, she was diagnosed with mild cognitive impairment. At the time, David, my partner, was wearing a pin of a brain on his lapel. She looked at him and she said, "Why do you have that thing on your lapel?" And he said, "Well, I'm a neuropsychologist. I work with the brain, so I have a brain on my lapel." And she said, "Oh, good thing you're not a gynecologist." This poor lady had just been given some bad news, and there she is finding a way to be humorous. And that is quite characteristic of these superagers, so they find humor. Even gallows humor, but they're playful.
Yes.
Some other characteristics. Superagers are curious and adventurous. They are open to new things. They tend to be good-natured, and they tend to look for joy. When these people were interviewed, that was one thing that came up over and over and over again, is that I go out looking to be happy. I expect to be happy. Don't always succeed, but I'm looking for joy and looking for happiness. Obviously, sometimes a tall order, but that was something that these folks said over and over again. And think back again to Albert Bandura and social learning theory. The person, the environment, behavior, they all impact each other. And so one of the notions is that these superagers might actually be creating a more favorable environment that is good for their brain because of these kinds of characteristics. Sure, I'll try it. I don't know anything about that, but let's give it a try. I haven't been there before. Let's go. Being open to things, looking for joy. Sleep. This was a little surprising. It was good, but not great. They tended to not have significant differences from people who are not superagers. They did have more routine, which simply means that they tended to do things on a regular basis, often at the same day. So they swam every morning, or they walked every Wednesday. They met their 3 friends at the diner to play bridge. And every Thursday, they tended to do things on a regular scheduled basis. They were involved in music and art, and interestingly, most of these folks were retired, but not all of them, but they often were involved with teaching or mentoring. It seems that having purpose, a sense of productivity, also is not good for the heart. It's not only good for the heart, it certainly is good for the heart. It seems to be good for the brain as well. These people are resilient. So among them is a concentration camp survivor, people who had histories of abuse and poverty. Very interesting, given what we said earlier about the fact that these kinds of adverse experiences can harm the brain, and we know they do harm the brain, and yet some of these folks were able to deal with those kinds of situations. These folks were not big TV watchers, but they did watch some TV, but they loved their downtime. They all said they found time just to sit on the patio and watch the birds. Sometimes that would be associated with an activity like reading or knitting, but not always. Okay. So, some final thoughts. As they say, it takes a village. From identification of symptoms to achieving an understanding and a diagnosis of what's going on, to identifying and implementing treatments, monitoring treatment, and then importantly, looking at non-pharmacologic ways of helping an individual. It takes lots of professionals, it takes family, it takes friends. The more involved, the more socially engaged, the more unlikely the person is able to thrive, even if they're dealing with a disease like Alzheimer's that is not preventable and not yet curable. And then lastly, I know you folks are going to hear about this in the coming weeks with some other speakers, but caring for the caregiver is so important. And getting back to the notion of good old Al Bandura again, we need to pay attention to maximizing and optimizing the environment in which people with dementia are living. And part of that is making sure that the caregiver, who's largely responsible for creating and maintaining that environment, is getting enough support and service and care as well, so that he or she can continue to craft an environment that is going to be as supportive as possible. Okay. So on that note, let me thank you so much for your attention and for coming today. And I'm happy to ask any other questions. Yes.
You helped me years ago with an amyloid condition that kind of simulates Alzheimer's, but there's no cure for it either or treatment. And I noticed now that I've had some spells, and I get a lot of numbness in my hands and lips and things, and they come in droves. I can't predict them until I get the numbness, but I seem to be not having as many, but I'm getting more rest. I notice I have to have sleep. If I don't sleep, then I go into a spell much more readily.
Yeah. So you raised a couple of points about the variability of symptoms. They can wax and wane, they can come and go. We know that stress can do that. Even if symptoms are brain-based, stress will exacerbate them and provoke them often. And the issue you raised about rest and sleep. And the super-agers, that was one of the most surprising findings, is that they slept okay, but not great. They all expected them to say, 8 hours a night, every night, I don't let anything get away of a good night's sleep. That just wasn't the case. But in general, I think that what you pointed out about making sure that you're attentive to good sleep hygiene, having a good sleep routine, that's really important because there are important things that the brain is doing for us when we sleep, and so that can help us deal with. And if we're rested and alert and have a better mood, a little more vigor, that helps us deal with ongoing symptoms that maybe our healthcare providers haven't been able to resolve for us. So being rested is really important. Yes?
It concerned me when early on you said some of the people who had the hardest time dealing with this were family members. Are there any programs, are there any ways to make that better for the person?
Yeah, excellent question. The question was, I made the point about family members having difficulty tolerating changes, especially changes in personality, behavior, mood, when dementia's been diagnosed, after stroke, after brain injury. And so, gosh, is there anything we can do about that? And happily the answer is absolutely. There are wonderful organizations, services throughout the country, and certainly in Wisconsin. And I don't know if you know Stephanie, though, the Alzheimer's Association in Wisconsin is just really robust with support groups and the Amazing Grace Choir and information, and all kinds of services. So, short answer is yes, absolutely. And because our society in general over the last decade has really is more attentive now to Alzheimer's disease and the havoc that it wreaks not just on patients but on families, there are lots of services that are out there. So ask around, ask Joanne, ask your neighbors, ask your primary care provider. There's lots available for us. Good question. Yes?
I've got two questions. One, how can one judge whether the Aricept actually slowed down the disease? How can we measure that? And the other one is, what about Alzheimer's is terminal?
The last part of the second question, what about Alzheimer's?
When you die of Alzheimer's,
Oh.
what does that mean?
Okay, so the first question was, in terms of Aricept, how do we know it's not delaying the disease progression? And that's because of all the data we have looking at patients who are being treated with Alzheimer's disease. And what happens is that in the same amount of time, they end up with severe dementia, just as patients not treated with Aricept do. However, the way they get there might be a little bit different. So they might have a little bit more modest curve of deterioration than the patients who are not treated with Aricept. Also, because it seems to diminish a little bit symptoms of irritation, agitation, impulsivity, it may also be that their caregivers, whether they professionals or family members, are better able to interact with them and to tolerate them, if you will. But the main point is that the outcome data tell us these people become severely demented just as soon as untreated people. There may be some modest benefit along the way. So, and the second question about Alzheimer's, what do we do? It is a terminal illness. You know, my dad's death certificate says dementia due to Alzheimer's disease. If something else doesn't come along and end the person's life, the Alzheimer's pathology will eventually spread to all regions of the brain, including regions or structures deep in the brain that are responsible for life-sustaining functions, making us thirsty, making us hungry, breathing, controlling our heart rate. Sadly, eventually all that gets shut down. For many people, however, Alzheimer's disease, because it puts people at risk for other significant medical problems, falls, other illnesses, pneumonia, there often is an opportunistic medical condition that ends the person's life, even though Alzheimer's hadn't quite yet finished its grisly task. Other questions or comments or ideas?
I think what you spoke about is so important. A lot of times people miss the beginning. So early intervention, meeting with your primary physician, and being treated with medication as well as living a healthy lifestyle can delay disease progression. So where you're doing all of these things, it delays serious disease progression.
Yeah. That's an excellent point. We can't stop it. Now we can slow it down. That's great news, but it's not as great news as we all would like. But so be attentive to everything else we can do, as Stephanie was saying, that can, in other ways, enhance your medical health, your brain health, and so on. And let me just add, this isn't something that I mentioned, but from a more personal note, you know, when my dad was diagnosed and began to show clear symptoms and impairments, he and my mom still did a lot of wonderful things. They traveled, we had family gatherings, we had trips to Broadway in New York City. My dad got lost in the train station, that was exciting. But it's not, let me hasten to add that it is not a situation where you say, oh, Alzheimer's disease, end of the game, no more happiness, no more fulfillment at all. There is still joy in life. We might have to work a little harder to find it, but it is not the end of the game, and we want to really be diligent in looking at ways to address all of our health issues, and to, as these super agents found, to be actively looking for joy at every stage of the process.
Would you want to introduce Stephanie very quickly so people here know her?
Sure. Want to stand up? So, Stephanie, I'm sorry, my own mentor, I'm not blanking on your last name.
Houston.
Stephanie Houston is from the Alzheimer's Association.
No, she's from the Wisconsin Alzheimer's.
Well, why don't you introduce her? I will tell you, I know Stephanie because my mom and dad were in the Amazing Grace chorus.
So this is the lady who's going to bring us the Amazing Grace Chorus on November 18th. But she brings much more than that. She's with the Wisconsin Alzheimer's Institute, which is an organization within the University of Wisconsin. Take it away, Stephanie.
Within the University of Wisconsin-Madison, we have distinctively a dementia diagnostic clinic that reaches throughout the state of Wisconsin. Those, as Jim was speaking on, are places where people can go and get diagnosed and receive treatment. So we have dementia diagnostic treatment. We also promote the advances in research. So we do research. We have individuals who participate in research. And here in our Milwaukee office, which is really important, we try to engage the community to make sure that people know about resources for support. We try to help families to navigate on the journey so that they know what they need to do, where they are, and make sure that their loved ones have quality of life. There's a lot that goes on before you get to the end. We really focus on the beginning, and like Jim was saying, finding that joy. And so we try to create inclusive programs to focus on healthy aging and quality of life, and reducing stigma in our community around people living with the dementia. And that is so important because stigma stops people from going and getting evaluations. It creates an atmosphere where people tend to be isolated. And that's not where we want to be. We want to make sure that people are aging well in our community. So that's just a little bit about what we do. And I look forward to the November 18th concert, and you'll get to see the Amazing Grace Chorus.
Thank you. Jim,
Yeah.
is that blood test fairly new, that diagnostic test?
Yes, the question was, is the blood test fairly new? It is. So the two of them I mentioned. The one to identify the APOE4 gene, that is not new. That's been around for probably 20 years. But the blood test to look for the downstream evidence of these abnormal protein problems in the brain, that is fairly new.
That's a big breakthrough.
Yeah, yeah. You know, Stephanie mentioned the importance of early identification, early diagnosis. We want to get in and provide pharmacologic, non-pharmacologic, therapeutic, social engagement. We want to get everything going, and that's really where the success is going to be, is very holistic, very comprehensive interventions.
Thank you.
Yeah.
Is there any purpose for all of those who are over 80 to wonder if you're okay today, that we'd like to get Alzheimer's tomorrow? I mean, it's a little late. I'm figuring I'm okay.
So it's never too late to better understand how we're doing and to think about ways to optimize our health. However, if your question is, you know, I'm 80 today, and am I going to get Alzheimer's disease next week? The cognitive changes emerge gradually. When there is an abrupt onset of cognitive decline, that we're looking for something else. We're looking for a stroke or some type of substance use problem, something not Alzheimer's disease. However, because well-educated, healthy, active, thriving people live longer, and because they tend to have really good brains, the pathology might express itself later. So whereas somebody who was overweight and had diabetes and was inactive their entire life, has 8 years of education, might have the same pathology, and they become symptomatic at age 72. Somebody who has lots of education, much denser neural networks, really good health habits, physical exercise, social engagement, the same amount of pathology they might become symptomatic at 82 or 84. So if the question is, well, I made it to 80, am I home free? Unhappily, I would tell you, no, you're not. In fact, your risk just went up because you've been another year, you've had another trip around the sun. However, if you got to 80 and you're not symptomatic and you're functioning well, that's very encouraging. So continue to do everything you can that we know is preventative, that will maintain your brain health and your ability to continue to thrive. Yeah.
Tell me about during COVID and afterwards, did you notice a lot more Alzheimer's in isolation?
So I don't think there was an increased incidence, but what we saw, yes, was that suddenly people who were afraid to go to the doctor's office and had just been sheltering in place, now they're coming up to get care, and so they're being identified and evaluated and diagnosed and treated. Yeah, you mentioned COVID too. This is a complete tangent, but there is some research that suggests that people who had COVID can be at risk for persistent cognitive difficulties as well. I think, especially in the popular media, it's wildly overstated, but there does seem to be something to that. So again, getting back to the notion of non-specificity and thorough diagnosis, when people come to us and they're concerned about their cognition, we ask about a whole range of health history factors, and COVID is one of them. Lyme disease is another factor.
Is there any new knowledge in the amyloid area?
Any new knowledge in the...
Amyloid area?
New knowledge in terms of how they can help the brain to clear it from the brain, but I don't think there's any new knowledge in terms of a heretofore unidentified type of protein or protein process. As I said, there's the beta amyloid and the tau are the proteins that are gumming up the works and causing these problems. I'm not aware of any new revelations in terms of
Treatment or anything?
protein. Yeah. Sure. No, I'm not. So you're just asking if I work at Freighter. No, I'm from Connecticut, actually. So again, I will tell you, if you have concerns and if you're not content with the care you're getting, ask around. You are. Oh, great. Good. I'm glad. So, yeah. No. So I'm not affiliated at all. Stephanie? Do you have an affiliation with Freighter?
Their neurology department is a part of the Dementia Diagnostic Clinic Network.
So I'll tell you what, we'll go wrap up here. I will stay here. If people do have questions or want to chat a little bit more, I'm happy to stay for a while. So thank you again, everyone. Appreciate it.
Thanks, everybody.
I'm sorry to hear that.